Hello, my name is Dr. Amy Wagelie-Steffen, and I am a practicing allergist located at Allergy and Asthma Associates of Tucson in Tucson, Arizona. It is my pleasure to explore TEZSPIRE, tezepelumab-ekko, the first biologic approved for the treatment of severe asthma without phenotypic or biomarker limitations. TEZSPIRE is indicated for the add-on maintenance treatment of adult and pediatric patients aged 12 years and older with severe asthma. TEZSPIRE is not indicated for the relief of acute bronchospasm or status asthmaticus. It's contraindicated in patients with a known hypersensitivity to tezepelumab or its excipients. Additional safety information will be provided during this presentation. Please note that this is a promotional presentation sponsored by Amgen and AstraZeneca, and there are no continuing medical education credits associated with this program. The objectives of this presentation are twofold. First, we'll explore the role of TSLP in severe asthma. Second, we'll explore TEZSPIRE, the first and only biologic approved for severe asthma without phenotypic or biomarker limitations. The airway epithelium plays an important role in the pathogenesis of severe asthma. In addition to serving as a barrier, the airway epithelium acts as an environmental sensor that responds to diverse triggers. In response to damage and other environmental triggers, the epithelium releases alarmins, including TSLP, which can activate multiple immune cascades, perpetuate inflammation, and drive smooth muscle dysfunction that can contribute to airway hyperresponsiveness. TSLP acts at the top and throughout the inflammatory cascade. By acting at the top of the cascade, TSLP is involved in the production of multiple downstream inflammatory mediators, including IgE, IL-4, IL-5, and IL-13, and it can activate immune cells, including eosinophils. In this way, TSLP can drive both allergic and eosinophilic T2 inflammation. We know that some patients do not have classic T2-driven asthma. Multiple factors, including the interplay between mast cells, airway smooth muscle cells, and airway hyperresponsiveness, can contribute to asthma in a T2-independent manner. By acting at the top of the cascade, TSLP can drive these T2-independent effects, which can be a feature of both T2 high and T2 low asthma. As you might anticipate from the previous slide, there is a growing body of literature that implicates a role for TSLP in the clinical and physiologic aspects of asthma. TSLP has been associated with increased asthma severity, reduced lung function, increased risk of asthma exacerbations, and the development of airway hyperresponsiveness. Clinicians have an approach for targeting TSLP in patients with severe asthma. TEZSPIRE is a human monoclonal antibody that targets and blocks TSLP at the top of the inflammatory cascade and helps prevent TSLP from binding its receptor. By blocking TSLP at the top of the inflammatory cascade, TEZSPIRE was shown to impact two hallmarks of asthma: airway inflammation and airway hyperresponsiveness. The mechanism of action and the clinical significance of this outcome and its impact on asthma have not been established. In the 52-week Navigator study, TEZSPIRE impacted the levels of three commonly used clinical biomarkers: blood eosinophils, exhaled nitric oxide, and total serum IgE. A reduction in blood eosinophils and exhaled nitric oxide was observed as early as week 2. That was sustained throughout the 52-week study. Please note that these results are descriptive only. TEZSPIRE also impacted tissue eosinophils and airway hyperresponsiveness in the Cascade study. Over 100 patients with severe asthma underwent bronchoscopy and biopsy after receiving either TEZSPIRE or placebo for up to 52 weeks. Treatment with TEZSPIRE resulted in an 89% reduction in airway submucosal eosinophils versus a 25% reduction in placebo-treated patients. The assessment of AHR was an exploratory outcome in the Cascade study. The figure shows the change in absolute dose of inhaled mannitol required to result in a 15% reduction in FEV1, otherwise known as the PD15. AHR, as measured by response to mannitol, was reduced in patients treated with TEZSPIRE versus placebo, with the end of treatment mean change from baseline being 197.4 milligrams with TEZSPIRE versus 58.6 milligrams with placebo. indicating a reduction in airways hyperresponsiveness with TEZSPIRE. As previously noted, the clinical significance has not been established. The efficacy and safety of TEZSPIRE was evaluated in two 52-week pivotal studies called Pathway and Navigator. Pathway and Navigator were randomized, double-blind, placebo-controlled exacerbation reduction studies. Pathway was a phase 2 dose-ranging study in patients 18 years of age and older with severe asthma. Navigator was a phase 3 study in patients 12 years of age and older, also with severe asthma. There were no baseline biomarker requirements for entry into either study. The primary endpoint of both studies was the annualized exacerbation rate. Collectively, Pathway and Navigator evaluated the efficacy and safety of TEZSPIRE in over 1,300 patients with severe asthma, with a history of 2 or more exacerbations requiring systemic steroids or hospitalizations in Navigator, or in Pathway, 2 or more exacerbations requiring systemic corticosteroids or 1 asthma exacerbation requiring hospitalization over the previous 12 months. Patients were randomized to receive TEZSPIRE 210 milligrams every 4 weeks, the FDA-approved dose, or placebo by subcutaneous injection. Patients in both studies remained on their background asthma therapy, which included medium or high-dose inhaled steroids and an additional controller medication, with or without oral steroids, for the duration of the studies. Once again, the primary endpoint in both studies was the annualized asthma exacerbation rate. The Pathway and Navigator studies enrolled a broad all-comer patient population. Patient demographics were similar between the two studies. However, the number of exacerbations in the previous year was slightly higher in the Navigator study. Patients were approximately 50 years of age and predominantly female. 9% of patients required chronically administered oral corticosteroids. The mean predicted FEV1 ranged between 60% and 63% predicted. So what do we mean when we say the studies enrolled a broad all-comer population? It means that there were no biomarker limitations or requirements for entry into either study. As you can see, patients had a range of blood eosinophil counts below and above 300 cells per microliter, phenol levels below and above 25 parts per billion, and the studies included patients with and without perennial aeroallergen sensitization. In a broad, all-comer population, TEZSPIRE consistently demonstrated statistically significant reductions in asthma exacerbations. In the Pathway study, there was a 71% reduction in asthma exacerbations, while in the Navigator study, there was a 56% reduction in exacerbations with TEZSPIRE compared with placebo. TEZSPIRE is the only biologic to demonstrate a statistically significant reduction in asthma exacerbations in patients with blood eosinophil counts less than 300 cells per microliter. Reductions in exacerbations, regardless of phenotypic profile or biomarker level, were observed in patients taking TEZSPIRE. In a post-hoc pooled analysis of Pathway and Navigator, fewer exacerbations were observed in patients receiving TEZSPIRE versus placebo, regardless of baseline blood eosinophil count, exhaled nitric oxide, or allergic status. These results are descriptive only. TEZSPIRE also impacted asthma exacerbations requiring emergency department visits, urgent care, or hospitalizations. Over the 52 weeks, patients receiving TEZSPIRE had an observed relative difference of 79% in exacerbation-related emergency department visits, urgent care, or hospitalizations. Similarly, there was an observed relative difference of 85% in exacerbations requiring hospitalization in patients treated with TEZSPIRE compared to placebo. These results are descriptive only. In addition, TEZSPIRE provided a rapid improvement in lung function that lasts in an all-comer population. At week 52, treatment with TEZSPIRE resulted in a 230 ml improvement in FEV1 from baseline, which was statistically significantly greater than the improvement with placebo. FEV1 improvement with TEZSPIRE occurred rapidly, with 70% of the lung function improvement achieved at 2 weeks and was sustained through 52 weeks. Please note that TEZSPIRE is not indicated for use as a rescue medication. adverse reactions that occurred more commonly in TEZSPIRE-treated patients versus placebo at an incidence of greater than or equal to 3% included pharyngitis, arthralgia, and back pain. TEZSPIRE offers one straightforward approach to dosing. TEZSPIRE is supplied as a fixed dose once every 4 weeks. There is no loading dose, no variation in dosing schedule, no weight-based dosing, and no dose adjustments based on biomarker levels.
Hypersensitivity reactions were observed in the clinical trials, example, rash and allergic conjunctivitis, following the administration of TEZSPIRE. Post-marketing cases of anaphylaxis have been reported. These reactions can occur within hours of administration, but in some instances have a delayed onset, i.e. days. In the event of a hypersensitivity reaction, consider the benefits and risks for the individual patient to determine whether to continue or discontinue treatment with TEZSPIRE. It is important to know that TEZSPIRE should not be used to treat acute asthma symptoms, acute exacerbations, acute bronchospasm, or status asthmaticus. Do not abruptly discontinue corticosteroids. Dose reductions, if appropriate, should be gradual and may be associated with withdrawal symptoms and/or unmask previously controlled conditions. Treat patients with pre-existing helminth infections before starting TEZSPIRE. If patients become infected while receiving TEZSPIRE and do not respond to anti-helminth treatment, discontinue TEZSPIRE until the infection resolves. Avoid use of live attenuated vaccines. Most common adverse reactions include pharyngitis, arthralgia, and back pain.
In summary, TEZSPIRE is the first and only biologic for severe asthma without phenotypic or biomarker limitations. TEZSPIRE blocks TSLP at the top of the inflammatory cascade to reduce inflammation. Patients treated with TEZSPIRE experienced up to a 71% reduction in asthma exacerbations, and there was a 79% reduction in exacerbations requiring hospitalizations, emergency department, and urgent care visits. Thank you for taking the time to learn about TEZSPIRE. For more information about TEZSPIRE, including the full prescribing information and patient information, I invite you to visit tezspirehcp.com or scan the QR code shown on the screen. Thank you for watching this video on the clinical details about TEZSPIRE, tezepelumab-ekko.